I'd like to now ask Milton if you would address our audience. I think a lot of you will have heard of Milton, and I hesitate really to try to make an introduction. You can do it very well for yourself, but all I can say is that when I have been with Milton on the picket lines at Tameside Hospital or at KONP stalls in Hyde, people have come up and been so delighted to see him and said, "Oh, you fixed my hip," or "You fixed my shoulder," and what better praise and recognition can there be than that? So perhaps you would please speak to our audience now. Thank you, Milton.
Thank you. Thank you, Barbara. And I will ask your forgiveness because I will read what I have to say. I would like to start thanking everybody for coming to this meeting. Since my retirement in October 2014, this is the first opportunity I have to speak to members of the public of Tameside and Glossop. And I would like to say that it was an amazing privilege to have worked at Tameside Hospital for 17 years, and indeed worked at the National Health Service for 40 years. I came here in 1974, and I always worked in this country. I never went abroad to work. So all my experience is related to Tameside, to the NHS, 17 years at Tameside. Over the years, I've been trusted with the care of thousands of patients, from newborn babies to the elderly, suffering from simple fractures to, in some occasions, life-threatening injuries. And of course, as an orthopedic surgeon, I dealt with painful deformities, arthritis, and so many other conditions. The only thing I could say is that for a good 25 years of those 40 years, I never had to consider targets or any form of rationing, which was the case over the latter part of my career. So for many years, I thought it was the best, I was doing the best job I could hope for when I came from Chile. And I really thought that the NHS was the best place to practice orthopedic surgery in the whole world. And I've been abroad many times for various reasons, and I can say that the NHS is held in extremely high regards across the world. Wherever you go, they mention it as really a shining light. But what has changed? Let me explain. I think everybody knows, and I've heard that over the last 25 years, the founding principles which are the base for the creation of the NHS has been gradually dismantled. And this is not a saying, this is what is happening. And this has happened regrettably in spite of the intense opposition from many organizations, such as KONP, the medical profession and their regulatory bodies, and the public. But nevertheless, as we all know, a bill was passed known as the Health and Social Care Act 2012, which gave legal basis for the changes that we're seeing now. One of them is that the Secretary of State for Health is no longer responsible for the health of the inhabitants of England. So the Act gives a framework that it allows, we like it or not, for a wholesale privatization, organization of the planning, supply, finance, and the distribution of health care is with us and surround us. We have to deal with it. On the other hand, when the NHS was created in 1948, and really until the last 10 years, but certainly until 2012, the GP and hospital doctors were the patient's advocate, and everybody was involved in care, from nurses to doctors to porters, did it without having the need to compete for the benefit of themselves or shareholders. And this is what's happening now. The situation has changed. It is not surprising, therefore, that sadly patients in some occasions question whether the decisions that have been made about their care are anything to do with their illness or their clinical complaints, but otherwise they may think they are due to commercial pressures on the people delivering the care. I think most politicians understand something about general practice and hospital medicine, but on the whole, their knowledge is not enough. And all the plans we see are flawed for that reason. They don't see the importance of continuity of care. They blame general practitioners or family doctors, an aging population which was alluded, people are living longer. The care is becoming more complex, they say, more costly. They blame weather changes, and we hear every year the winter pressures. Well, the winter pressures occur throughout the summer now. What they don't say, the politicians, in my view, is that all what is happening with the National Health Service and the provision of care is really the direct result of policies that have been mandated over the last 25 years. So what are these policies? First, in 1991, the introduction of the internal market. That splitted the National Health Service into purchasers and providers. Shortly afterwards, they began to create first hospital trusts, which later became foundation trusts. When I first came to this country, the hospitals were managed by a hospital secretary. There were obviously administrators, but there were no boards of directors. Nowadays, the trusts, they are targeting people with experience in commerce because they see the provision of health as something that got to generate an income, etc. As you will see later, this has now been questioned. So they began to introduce a commercial competition between trusts and other private providers, rather than a spirit of cooperation between hospitals. That existed when I first came here in 1974, but it was gradually lost. And it was lost because we lost all the institutions that allow for that. The regional health authorities, etc., were lost, they were dismantled. What other policy was really damaging for the NHS? Private financial initiative contracts. In Tameside, I know for a fact that this cost us millions every year. The hospital, the new wing that was built, cost 70 million, and when we finish paying for it, it will be something approaching 300 million. So it's really very, very expensive. And across the country, the private financial initiatives are one of the main reasons why the NHS is having a crisis regarding finances. And finally, as I said, the Health and Social Care Act, which regrettably was supported by every political party, and that was, in my view, a mistake. So what has happened? What happened now is that general practitioners and hospital doctors alike, we are restricted in terms of where we can refer patients and what treatment we can use. There is rationing, there are lists compiled. As a consultant, on many occasions I saw a patient with a hip problem, but I realized that he had a cardiac problem either to not diagnose. The rules of my hospital were that I could not refer the patient internally to a cardiologist because the GP will charge the hospital. And therefore, the doctor had to see the GP, etc., which sometimes they couldn't understand. So as a hospital consultant, I couldn't refer a patient coming to me with something which had not been yet diagnosed without the permission of the GP, which many will say, well, that is the correct way, but the patient couldn't understand that. And the GPs have got the same problem. I'm sure many GPs, they want to send the patient for a treatment to ex-consultant and they can't. I already mentioned the rationing. Rationing, it does exist. Certainly in my specialty, I saw it virtually every day. There are certain targets that we cannot exceed, and patients got to wait. And that's just one example. I began to see a few years ago the data financial spreadsheet telling me what activity I had done, where it was too high or too low, it was costing the hospital too much or too little. One thing I could never understand when I was working at Tameside was the fact that on their wisdom, the National Health Service allocate a budget which is finite for what they call acute care in the A&E department. And if that budget is exceeded, say before the end of the financial year, the hospital is penalized. It's like saying, we have a budget for fires in the community, which is X, but these are many more fires than we expect this year. You won't have the money to cover the cost of extinguishing those fires. We don't know how many patients will come through a casualty. We have some idea, but I don't see why a hospital should be penalized for that. And I would never receive a satisfactory explanation. So the pretense that general practitioners are now in control of their money, I don't think it has been kind of found to be flawed. We all know that most services now going to tender, and that is also a factor that concerns me. Clinical decision making is not longer, in my opinion, on many instances, with the best interest of the patients at heart, because there are financial considerations to be made. Another problem with the commercialization of the care is that some patients are told that what they need is no longer commissioned by a particular practitioner or consultant or GP. It is if that particular ailment is not on the list, the patient will be sent somewhere else or simply not treated. However, what it is always there is the implication, in my view, that patients can avoid long waiting lists or avoid delays on their treatment if they use private medicines. And if you open your laptop, you will see it coming more and more as urging patients to take private insurances to cover because the NHS waiting lists are too long, etc., etc. That has always existed to a healthy degree, but nowadays I think it's becoming more and more prevalent. The need for patients to choose to have a private health insurance to cover the illnesses. The politicians who drive all these changes claim, however, that the NHS is not being privatized because still they say it's free at the point of use. But this is not true. The two things are not connected. We all know that patients sometimes go and see the general practitioners and they are sent, yes, they don't pay, but they are sent to a private clinic or some sort of enterprise that allows them to have their treatment. But it is a firm that is private, has got shareholders or got an owner, etc. Therefore, there is sometimes a conflict of interest. And this is something that has been, discussed as well. Many general practitioners, they have got interests outside their normal practice, and those interests are linked to private companies. We all know that. Obviously, they have been trying to regulate it, but it is one of the concerns I've got as well. Now, the NHS, in my view, as I knew it when I came to this country, has gradually disappeared. Now we've got NHS England, which my understanding is the name given to the main of the commissioning national bodies. The fact is that it has disappeared. It has remained as a logo that we see it attached to a lot of private companies, but the NHS, with all the institutions it had, the primary care trust, the regional health authorities, it has disappeared. That's why we have created others to try to supplant them. In summary, in my view and the view of a lot of academics who have studied this issue, we are one small step to get insurance companies to pick up the bill for many illnesses that the population of Britain is suffering or will suffer. And as Jeremy Hunt, the current Secretary of State for Health said, it appears to be the end of a 60-year-old mistake, meaning the NHS for him was a mistake, which I profoundly disagree with. Now, what about the future of Tameside Hospital as we know it? I believe that the model of care proposed by the contingency planning team, which is a creation of PricewaterhouseCoopers, the accountant, the international accounting firm. This model of care is deeply flawed. I'm not sure if people is aware of this. Their report was submitted to Monitor July 2015, so it's almost a year old. Why I say this report is flawed with respect to the future of Tameside Hospital. And before I said further, don't take me wrong, I am all in favor of integrating care between the hospitals and the community. In this case, between the hospital, Tameside, Bureau Council, and the clinical commissioning group. Those organizations should be integrated. The reason why I said the report is flawed is because it is based on a reduction of the acute beds of Tameside by 246. Currently, the hospital has got something like 470 beds or thereabouts, so they are planning to close more than 50% of those beds. Now, this figure, I read the report from A to Z, appears to me out of thin air. There is no rational explanation other than this reduction in capacity can be compensated by the creation of 5 local community care teams. Now, I could envisage a gradual, over a period of perhaps 15 years, reduction of that bed capacity, but not over the period that is proposed, which I presume is between 2 or 3 years, half the number of beds at Tameside Hospital, I just don't see it. I have never been a GP, I've never done, other than doing domiciliary visits, who were very popular 10, 15 years ago. Seeing a patient in the community, it takes time, you got to find the address, you got to drive, and I don't see how a team can be moving from house to cover a number of patients. I mean, to me, it's almost like they're trying to discover, the wheel once again. Hospitals were arose, from historically, because there was a need to have specific places with trained nurses, trained doctors, physiotherapists, occupational therapists. The rest of the team, and it's more efficient to see patients which are acutely ill in hospitals. Nowadays, it seems like we have forgotten that having patients dispersed in the community, I'm talking about patients ill, not patients which are having a cold or something, but the fact of the matter, that is the reason why I found this this contingency care report deeply flawed. But the problem gets more complicated in any case with the release of the Devo-Monk document by the Greater Manchester Combined Authority, which set up the basis for even larger changes. Again, I've read the report from the beginning to the end, and I found it very interesting. It got a lot of many good points on it, the part on prevention, the part of integrating housing, etc., etc. I mean, I found it fascinating, to be honest, and I'd say I wish it would have been passed to the population at the time it was printed, which was, again, December 2015. Yet I wasn't aware of it until recently because it has not been publicized. A little bit like the PricewaterhouseCoopers report. How many have seen the report from PricewaterhouseCoopers? No one? I'll give you the PDF because it's in PDF easily found. Now, what this report quite rightly says is that there is dedicated staff which deliver high quality care to the population of the region in the face of growing demand and tight budget. That is true for all the hospitals. But what the document doesn't say is that in turn these tight budgets are the direct result of the wrong policies, which I said before. Of course, they won't say that. But for those of us which have worked in the NHS as long as I have, I know that this is the result of the accumulated mistake by politicians of all political parties over the last 25 years. So as a result, the present system is not financially sustainable, and we know that. The total forecast deficit for all these 14 provider organizations in the Greater Manchester is set to be 1.4 billion by 2020-2021. And this take into account the cost of what they call efficiency improvement. The Greater Manchester Combined Authority document states that the NHS trust in Greater Manchester must change and evolve to meet today's demands and the changing demands of the future. And we hear that mantra again and again and again, this aging population, the demands of the future, etc., etc. What it doesn't say is that these demands are due to payments we have to make across all the trusts year after year, for instance, for the PFI. And I keep saying the PFI across the nation were a gross mistake, and if you coming here learn anything about it, is that wherever institutional meeting you are attending, because there's still somehow the flavor of politicians Schools have been made under PF5. They are even exporting the idea to other countries, such as where I come from. I hope it never happened. But, so this document reveals the plan for the acute services, and within those plans, this integrated care organization planned by Price Cooper Waterhouse, it will kind of fell into, if you like. I would say a little bit more about what they call efficiency savings. As a consultant at Tameside, year after year, we were put in a situation where we have to say some years up to 4% of our budget. This document talks about 2.5% for the present year, and to be continued by 2% efficiency savings over subsequent years. It doesn't say for how many, but in my experience, these savings will continue to cause immense harm to patients which have been treated in these hospitals in Greater Manchester, and also they will cause harm to the employees, including the nurses. Nobody will be saved. The porters, the cleaners, everybody will suffer, the secretaries. Why I say that? Because I suffer it year after year. And I attended meetings at Tameside. I could give you the figures when the chief executive will say, all right, this year we got to save 2 million in nurses, 1.5 million in doctors, 750,000 in secretaries, etc., etc. Total 17 million we need to save this year. And the basis for those cuts, absolutely out of the air. Nobody understood it. And those changes, those savings have got to be made recurrently, year after year, as this document says. Now, I challenge you, housewives and, holders of the budget of your houses, if somebody said to you, look, you are living fairly comfortable now with this salary, but this year you got to save 4%, next year another 4%, you at the end you will say when this is going to end, particularly when you are not earning more, because they are giving you the same, if not less, budget every year. The other chip in my shoulder I got, and I would like to say, particularly to doctors which are attending today, which I really would like to see what they think, is this document talk about improving delivery of care by avoiding emergency admissions. And I do not get it. I understand and I agree that we should cut the very long length of stay for acute illnesses in hospitals. We're trying to shorten the period of stay, etc., etc. But these policies, which have been around for the last 10 years now, including papers that have been quoted from other countries, including here, saying that patients, we should avoid admitting emergency patients. I just don't get it. In my opinion, hospital admission avoidance policies have evolved because there has been a relentless closure of hospital wards and beds across the NHS. And why this has been necessary? Because the hospital need to keep a balance on their books. That's why they have cut the beds. It's not because it led to better care of the population. And that's happened across England. We all know that in contrast, other European countries such as Germany and France, as many as twice many beds are here in Britain. For instance, France has got 7.65 per 1,000 people, Germany 8.27. Now here, the current figure is 2.9, so we have got even less than half of those other two developed countries. We all know that these low levels of bed led to cancellations of operations, etc., and we all know the press has reported on that at large. What is more important, or just as important, is that as a result of the lack of beds, a significant number of patients of all ages who should have been admitted are sent home, and many suffer disastrous consequences, including death. I know about children which they go around the block, they go around ringing 111, every set of computer program, every path, every obstacle they need to cross, it will lead them not to being admitted. And sometimes that is not good, and patients do die. One good thing on this is that it's talking about collaboration between the trusts. Even goes into criticize, and it's good. It criticized the dogma, which was prevalent and still is prevalent in some part, that competition between hospitals was good, because we were told to compete for patients coming to my trust, not to that trust, etc., etc. They're now talking about collaboration, and that is excellent. It's good news, because it will bring a better service. Unfortunately, what this document doesn't say, and I will say it once again, it doesn't criticize the PF5. It goes around the way and it said that it will look into the contracts of these 14 trusts with respect to PF5, looking for ways to improve the advantages. But in my view, PF5 do not give any advantage, they give disadvantages, as it is well shown. In summary, and I'm sorry I've gone a bit long, I'm extremely proud to have been an NHS doctor for 40 years and a surgeon. It is my belief that a society such as ours should be valued according to the way it delivered health care. Our values up to about 15 or 20 years ago were, for me, the perfect ones. Nowadays, unfortunately, we are moving into a system very similar to the US health care. And this should not be a surprise for anyone, because, our main manager, who will be the chief executive of the NHS, Mr. Simon Stevens, he trained in the USA or worked there, and in my view is trying to introduce that type of healthcare into our nation, and I simply do not accept that. So we are being dragged into a system where profit is what is the aim, and I for one, I don't want to be part of it. I would finish by saying that the politicians which are responsible for these changes, they must live with their consciences. I see the changes that are happening now as one of the greatest failures of democracy, and that is regrettable. And finally, I urge those of you that believe that this is the case to join organizations such as KONP and fight, in our particular case of Tameside and Glossop, against the closure of more than 50% of our hospital beds. By all means, support the integration, but do not let the hospital to disappear so many beds in that fashion. And thank you very much for listening.